Thank you for choosing Axxess On Demand. Axxess believes in continuing education, and we create content to empower you to learn and grow anytime, anywhere. Let's get started.
I'd like to introduce today's panelists. First is Tammy Ross, Senior Vice President of Professional Services with Axxess. Bill Dombey, President of National Association Home Care and Hospice, and David Merck, Executive Vice President for Axxess. And I'm going to turn it over now to Bill. Bill?
Well, good day, everybody. If we can put up my first slide, we can get ourselves going. All right. We want to find out why PDGM, why the Patient-Driven Grouping Model. I mean, we consider this to be a revolution for home health agencies to provide Medicare services. Now, how did we get here? There's a long history to reimbursement models in Medicare home health, but why are we now here with this new payment model? Well, the purpose of this new payment model is to address two different concerns that have been raised over the years. One concern is that the existing payment model doesn't necessarily provide adequate reimbursement for all of the types of patients eligible for the home health benefit, that there are some patients that might fit into the vulnerable patient category. So it's interest to be served then in trying reforming the model so that that patient population can avoid any barriers caused by payment. The second and predominant reason we're in PDGM is that it's intended to address concerns that have to do with the utilization of therapy services. That when the new payment model was devised, that was goal number one, because over the years, concerns have been raised by Congress, by CMS, by the Office of Inspector General and the Government Accountability Office, that the existing model incentivized high volumes of therapy services because reimbursements were increased accordingly. We see great value to the therapy services that have been provided under the Medicare Home Health Benefit. Others, like the OIG and the Medicare Payment Advisory Commission, see overutilization. So eliminating an incentive, they feel, will bring a greater clinical focus on the patient's overall needs rather than just on reimbursement. So what does that mean? It means the home health agencies are going to see a shift in reimbursement. This is a redistribution system that will spend the same amount of money but spend it differently. And one of the areas that it will spend differently will be on therapy-related episodes of care. Invariably, those will receive less reimbursement, but I caution people not to jump to conclusion. While it might mean less reimbursement, the resources that include therapy services for those types of patients have been included within this model. So purpose, taking care of vulnerable patients, limiting therapy thresholds. What does it mean to agencies? May mean some adjustment of practice, or it may mean a rebalancing of their patient population so that they can serve both vulnerable patients as well as therapy patients. What's the impact that could come to agencies more than anything else, though, we see coming from behavioral adjustments to payment rates? A behavioral adjustment is a prediction-based assumption as to how home health agencies will change their operations, change their practices in a number of different spheres, including diagnostic coding, the use of comorbidity references on claims, as well as some of the factors created by the architecture of the model that relate to such things as where's the patient coming from, hospital versus home, what the patient's length of stay is with early versus later episodes of care, but most importantly, the change to the LUPA model, and there'll be discussion about the LUPA model and whether or not individual agencies will add visits to overcome LUPA thresholds. All of that is factored into a behavioral adjustment to payment rates, something which we addressed with the HHGM proposal from 2017, but CMS is looking at the kind of behavioral changes and putting CMS in a position to adjust payment rates downward to account for upcoding on diagnosis, inclusion of more visits for the LUPA patients and the like. So what should we expect? We should expect that the next 8 to 10 months is going to be a very advocacy-oriented month to try to convince CMS to back off of behavioral adjustments, back off of rate cuts, as well as congressional action. So that we wanted to give you that starting point, that overlay, while the rest of the faculty here will be taking you somewhat into the depth of PDGM. So turn it over now, I believe, to David.
Yes, thank you, Bill. I'm going to talk today about some key PDGM impact realities. The patient-driven grouping model, as Bill has said, introduces sweeping changes. It's revolutionary, and it affects each agency differently. With OASIS and visit history, we can project the financial impact of PDGM, and we can do this for any given agency. Now, CMS has done this, but CMS's agency-level impact spreadsheet may have resulted in an unwarranted sense of security regarding PDGM. First, about PDGM, piecing it together, how does it work? Payment is set for 30-day episodes, but billed at 60-day intervals. HHRGs, HIPs, LUPAs, and outliers, those concepts, those practices are retained. Each HHRG has its own LUPA threshold, and the threshold is almost always higher for the first payment period within a 60-day period. The patient's functional deficits help determine the case mix, but a count of therapy visits does not. Case mix levels for HHRGs have been developed to shift payment to priority services. For example, generally speaking, wound care is up and rehab is down. How is case mix determined? Based on claims data and an OASIS assessment, the episode is assigned to one of 12 groupings. This is based on the primary diagnosis on the claim, just the primary diagnosis. If the primary diagnosis does not fit into one of the groupings, there will be no payment at all for either 30-day period. In addition, it's categorized as early or late. Generally, the first 30-day period after the start of care is early. All episodes after that are late. It's assigned a functional score, low, medium, or high, based on information that comes from a number of OASIS items relating to functional ability. And it's assigned a comorbidity adjustment, and this is based on diagnoses which interact with the primary diagnosis. This is scored as none, low, or high. Finally, based on claims data gathered and organized by CMS, the episode is categorized as an institutional or community referral. Generally, these determinations apply across both 30-day payment periods. The same OASIS assessment and claim data will be used. We have 12 clinical groupings, 2 timing options, 3 functional options, 2 admission source options, and 3 comorbidity options. And when we multiply all that out, it yields 432 combinations compared with 153 for PPS. And each combination has its own LUPA level, ranging from 2 to 6. We'll use an example for a more detailed look at PDGM impact. It's based on 2,339 claims from 2018 for a sample agency, and the analysis includes both LUPAs and non-LUPA episodes. In this example, we have total revenue of about $6.5 million, and you'll note that payment for LUPAs at $459 is about 16% of what it is for any episodes that have more than 4 visits. CMS projects that PGM will be revenue neutral. National LUPA rates will drop from 8 to 7.1%. And they support this by noting that some episodes that were LUPAs will be fully paid under PDGM. And they also project that resources will be shifted to priority groupings, as Bill mentioned. Comparing PPS and PDGM payments, there are 4 possible payment outcomes under PDGM. First, some episodes are not paid for at all. In the example, this amounts to 13.4% of the 2,339 episodes, a significant number. Secondly, episodes might be paid for for the first 30-day period because they were discharged in the first 30 days. So they're fully paid for that one portion of the 60 days, therefore paid less than they would be under PPS. Third, episodes can be paid for a full rate for both 30-day periods, in which case the payment exceeds the payment available under PPS by about $600. Fourth, they can be LUPAs. They increase, LUPAs increase, but you'll notice that they're paid at a significantly higher rate, about 3 times what they're paid for under PPS. As you can see, In this example, the total revenue decreases by $665,000. How does this differ from CMS's impact analysis? CMS ignored the sizable portion of episodes that have a diagnosis that was not accepted under PPS, but will not yield a grouping under PDGM. As a result, CMS dramatically understated 2017 revenue. In the example, PPS revenue would be reported in the CMS instance as $5.7 million as compared to PDGM revenue of $5.8 million. This enables them to show an increase of almost $77,000 rather than a decrease of $665,000. Overall, projected PDGM revenue was nearly identical to that of PPS in their projections using the 2017 claims data. It was $16.1 billion under either PPS or PDGM. But interestingly, payments for 2016, the year before, were reported to be $18 billion. And I'm expecting that the total payments for 2017 were higher than that $18 billion. Therefore, there's a couple $1 billion missing. If you've looked at the CMS PDGM agency level impact projection and like what it shows for your agency, you might like to do this little test. Compare the amount CMS shows for your 2017 PPS revenue with what your company records show for PPS revenue for episodes ending in 2017. Even though the PDGM projections are based on the higher 2019 rates, I suspect that you will find that your actual 2017 receipts are significantly higher than what CMS shows on its spreadsheet. Then compare CMS's PDGM revenue projections with your actual 2017 payments. This will give you a better picture of impact. The key issue is diagnoses. 40% of the diagnoses currently in use under PPS will not be accepted. This is not unreasonable. PDGM is focused on paying an amount related to the expected cost of appropriate care. For the most part, the drop diagnoses don't provide the information needed to help predict cost. They primarily consist of R codes or symptom codes, things like other malaise, other chest pain, cough, dizziness, giddiness, weakness, or diagnoses which specifically indicate that they are unspecified. Now, not all of the unspecified diagnoses that say unspecified are excluded. Most were in the draft regulations, but in the final regulations, many of those were put back in. Now, these diagnoses, R codes, unspecified, appear on about 12 to 15% of current claims. So the bottom line for the home health industry is that PDGM is revenue neutral for episodes that have a qualified primary diagnosis and a disaster for those that don't. What is the fix? Ensure that your coders are prepared. Seek cooperation from referral sources. You can check diagnoses at referral to see whether they will work, and then press your referring parties for more information. You need to work with provider associations and others to educate your common referral sources about the PDGM change and what you will need to have in order to survive in and after 2020. This won't be quick. Agencies have a long history of struggling to get sufficient timely information for coding. You can also prepare your staff to provide plans and documentation that are consistent with and supportive of your diagnoses. You can't just move diagnoses around and make something else the primary diagnosis if that's not what you are primarily working on. So get everybody on board now, because the next 11 months will go very quickly, and it's going to take work. I want to talk a little more about LUPAs. CMS says they will decrease. I expect them to increase. In our example of the episodes that were LUPAs under PPS, 33% would not be LUPAs under PDGM, but 67% still would. As CMS notes, some will even be paid the full rate for an episode for all 60 days, but this is extremely rare. That would occur only when you had exactly 4 visits and thus were a LUPA in PPS, but those were divided evenly between the 2 30-day periods, and you were in HERGs which had a level LUPA threshold of 2 visits for each of the 30-day periods, which is extremely rare. Other episodes will be treated as full pay for 30 days and then discharged. There'll be 4 visits within the first 30 days, and if the threshold for that 30 days is 4, 3, or 2, this will work. But if it's 5 or 6, it won't. On the other hand, in our example, in addition to those that were formerly LUPAs, in our example, 11% of the episodes that had not been LUPAs under PPS would not exceed the LUPA threshold for at least one of the 30-day periods. So the result is that we're looking at an 18% figure for LUPAs, a 19% figure for LUPAs, as opposed to a 15%. And in some instances, it's quite a bit worse. Note that an episode which has as many as 9 visits could end up with both periods being treated as a LUPA, depending on the HHRG. So you can expect that LUPAs will add another level of uncertainty and complexity to agency management. Just knowing what the LUPA threshold is for a given 30-day period will be difficult because each one can be different. In closing, PDGM is a reasonable effort by CMS. What is the intent? They want to solve long-standing concerns regarding the PPS model. It succeeds in reducing certain gaming risks and in shifting payment to priority needs. But it's a major change that will affect each agency differently, and it poses a major risk: no payment for episodes that lack an appropriate primary diagnosis. Thank you. I guess I will turn it over to Tammy.
Okay, thanks, David. So when we're starting to look at risk, you know, no organization has probably experienced as many changes as home care industry in the last several years. We should be getting really good at change management at this time, out with the old, in with the new, right? So when we're looking at change management, we have to make sure that we have a culture that's going to embrace that change management. So I just want to briefly review a few concepts of change management if we'll go to the next slide. Looking at change management, it's how we guide and prepare and equip and support individuals to successfully adapt to change, to drive organizational success and outcomes. We can use the ADKAR model to kind of look at those concepts. A, being awareness of the need to change. Well, we certainly have an awareness. CMS has put out lots of information. We actually don't have a choice in changing. We have to change to this model, so the awareness is there. We have to have a desire to support and take part in that change. And when I say we have to look at the people that are going to be impacted by change, because people are going to be impacted very differently. If you're looking at a therapist's view of PDGM at this point in time, it might be quite different than someone that may have job opportunities as a clinical documentation specialist. So there's going to be different motivations involved in the desire to change. We have to give them knowledge of how to change. And I have to say, I think our industry is doing a fantastic job putting out education surrounding PDGM. There are many thought leaders out there, many organizations that are putting out free webinars, free white papers, and there's really no reason for us not to have the knowledge of how to change. We have to have the ability to implement that change. And some of that's going to require a different skill set, training our staff in a different way, reorganizing our operations, looking at that for the most efficient and effective processes. And then, of course, we have to reinforce that change. So change may happen, but does it stick, right? We have to inspect what we expect. So if we'll move to the next slide, we're going to just look a little bit deeper into some concepts that are fundamental for change. We talked about that culture. Is it right for change management? Are your employees engaged? And do they understand what PDGM is and the rationale for that change? We can't change an organization without changing its people. So we have to really work on a change management plan that's directed toward the different subsets within our organization. Intake change is going to be quite different from the change on the clinician and the change on the therapist. Remember, resistance to change is inevitable, and there's reasons for that. You know, we have fear of the unknown. It's probably one of the biggest reasons for change. The other reason is possibly, you know, the older we are, the harder it is to get us to change. Tall trees and big trees have very deep roots. If you take a nurse that's been in home care for quite some time, it was really, really hard to get them to switch over to PPS mentality. I remember trying to do that, and the nurses that had been in home care a while had the hardest time switching. So just remember, there is going to be resistance. And commitment to the past hinders the future. We've always heard, but I've always done it this way. You know, this is the way I've done it. This is, you know, why? Connecting the head and the heart builds commitment. You know, when you're talking to clinicians, they really don't care about the financial impact as much as they care about the heart of the clinician. And so, like David said, you know, the motivation for change is to serve the underserved. We can all get behind that and support that. So making sure that our clinicians understand that PGM has to occur, and it has to occur for good reasons, and that's to support our underserved community. Effective communication, we have to say it often, and we have to have it quality communication. And we have to send the same message. Each leadership, each manager, all the way down to our clinicians have to hear the same message. In the absence of communication, and I'll say even over communication, people create their own reality. Rumors, that's when the rumor mill is going to get started. So we have to communicate often and effectively. People support what they help create. So this is where we want to get your teams involved. Let's get some PDGM champions. Let's do some subcommittees. Let them come up with the reasons for changing in PDGM, the reason for reorganizing their operations. I kind of equate it to going to church. They always give you a job because they know you're going to show up on Sunday morning. So give everybody a job within PDGM, and then they're going to show up to the table. Sustaining change requires reinforcement. Again, looking over their shoulder, making sure that you have methods in place. What are we doing as far as data analytics? What are we doing as far as looking at intra-episode management to make sure we're supporting that change? And there's going to be unexpected outcomes, so you have to plan for that. Don't expect it to go completely smoothly when you do your beta testing. And leaders, your actions speak louder than words. Someone had asked me my best advice I was ever given, and it was by my mom. And she told me, someone's always watching you. And I will say that to a leader, someone's always watching. So we have to be careful at how we're presenting PDGM. David talked about that, this model, the PDGM model. But I just wanted to show this to you and say, wow, is there not risk here? Look at what we're moving to and what we're moving from and what we're moving to. We thought it was confusing under PPS. Let's move from 153 to 432 payment groups. Looking at community versus institutional, early versus late, 12 different clinical groups. And by the way, the majority CMS predicts will be in the MMTW group. Over 60% we predict will be in that group. Looking at functional level OASIS and comorbidity. Less and less is going to come from the OASIS and what our clinicians document, and more is going to come from claims data. So off of this scale, the only thing that's actually going to come from our documentation will be the coding piece of it and the actual functional scoring. So we have less influence over this model than we have in the past. So when we talk about risk management and how to determine risk, there's two models I want to just briefly mention. I think most of us are very familiar with the SWOT model, where we look at strengths, weaknesses, opportunities, and threats. Strengths and weaknesses are going to be internal to your organization. There are some wonderful predictive analysis tools out there now that can help you get to your strengths and weaknesses. And then looking at your opportunities and threats, I just want to mention, again, what Bill talked about, the behavioral adjustment. That's a huge threat to us as an industry. And I would just encourage you to go on our association's website. You can actually go in and you can let your voice be known to Congress about these behavioral cuts that are planned for 2020. The more people that speak out, the more opportunity we have to affect this change. And we have a real opportunity by letting our voice be known to actually, make that change so that we don't have the behavioral adjustments. I believe home care is the most effective and cost delivery method for post-acute care industry. And we need to reflect that in our payment reimbursement. Enterprise risk management model. When we look at this model, a lot of people look at this and they think about CPQI, OBQI, because it's circular. And it's circular for a reason, because it's continuous. We are always having to test and retest. We want to analyze and identify our exposures and examine our risk technique, and then select our risk technique, implement it, and then monitor the results. And if it doesn't work the first time, we're going to start back over and we're going to do it again. That's enterprise risk management. It's a little bit more detailed than SWOT, and I suspect we're going to be using both of these tools as we look at determining our risk. So we put out a few agency risk indicators. I want to thank our clinicians team for helping me look at these risks. And number one and foremost is our culture and our ability to implement change management. Our next one will be our control of missed visits, which is associated with our LUPA rate. What are we doing now for those people that just don't do a visit on Friday and we don't get it rescheduled on Saturday? Therapy utilization is going to be a bigger risk for some organizations than it is for others. And when we look at therapy utilization, we're still being held to outcomes management. So we have to look at therapy utilization and still determine how we're going to meet those quality outcomes. Ability to manage increased billing demand. We're going to have essentially double billing demand. Can your organization support that? Case management and intra-episode management, looking how that case is managed from intake and referral all the way to the end. We know this is going to be a very big challenge. I think about face-to-face and what a challenge that was. That kind of seems easy compared to the information we're going to have to get for coding now on the front end. Management of your workflow. How is your workflow managed for efficiencies? Who's the person that's communicating with your referral sources? How is that information coming into your software system? Those are all areas that need to be looked at. How do you onboard and orient your staff? Do we have a formal onboarding process? Are you orienting them thoroughly into not only what PPS is, but what's coming up in PDGM? Looking at referral source, community versus acute, CMS does predict that most agencies will have more community versus, more acute referrals versus community, but we know there's agencies out there that have more community referrals, and they get very little acute referrals. So that may be a risk for some of our agencies. Intake process, retrieval of that information. Are we working with our referral sources, and are we working with our electronic management systems for how that referral information comes into your vendor? Coding is huge. Have we considered coding partners if you're coding internally? What are your coding partners doing to update your staff about PDGM codes? What is your vendor software company doing to update you about potential PDGM codes that aren't going to be applicable in 2020. Primary diagnosis being supported and comorbidity diagnosis being supported. Now that there's payment tied to comorbidity, we're going to have to be very careful with those codes because CMS is going to monitor where the dollars follow. So if we're coding diabetes as a secondary diagnosis, we're going to have to make sure we have interventions for that diabetes and a plan and a goal for that diabetes. So it's going to become very, very important that we support that. Some agencies, as David showed us, will have a loss under PDGM. So what are we doing to prepare for that potential revenue loss? And as I mentioned before, software vendor, and what are they doing now to prepare for PDGM? So I want to talk a little bit about opportunities. If you look at this glass, the glass on the left and the glass on the right, I happen to be a half full type of person. I look at things from the half full, glass half full, not glass half empty. So I think we can use this as a huge opportunity as an industry to explore opportunities within PDGM. One of the biggest ones being telehealth, telemonitoring. We know that that can be included on the cost reports now, and that's big for our industry. Telehealth and telemonitoring can give us the data to support those secondary diagnoses. They may be a solution for home exercise programs for our therapy rehab patients, and it may be a way to more cost-effectively manage our cases if we are going to have those revenue cuts. So telehealth, telemonitoring, and looking at partnerships with companies that provide that information. And I know when I mentioned this before, I've had agencies say, well, then that's just more staff that has to monitor the telehealth and telemonitoring. There are companies out there that provide that support staff that actually have touch bases with them on the phone by a case manager, registered nurse. So I think now's the time to start exploring opportunities within telehealth, telemonitoring. New program development. Maybe it's a time we start looking at new programs. Behavioral health is going to be one of our clinical categories. Many agencies shied away from behavioral health programs. This may be a time to look back into that. Also looking at management and evaluation again for patients that are chronic care. Again, this is one that we haven't wanted to touch in a long time because it was a probe. People were getting audited for it, but maybe it's time to start looking at new program development. And then also looking at program development in the form of creating additional divisions possibly within your organization. We know that people are looking at potentially adding hospice, adding home care / private duty. These are all additional revenue streams for our industry. Certified clinical documentation specialist. This is something that's been in the hospital system for quite some time. They're not necessarily nurses, but they certainly could be nurses. These are people that had advanced education in coding, medical terminology. They're able to assist an organization with getting that information up front that we need to code correctly, as well as monitoring that case throughout the episode for outcome-based quality of improvement. So maybe exploring this job title and new operations related to certified clinical documentation specialist. And I'm not even sure they have to be certified. They can certainly be trained in areas of coding and OASIS. Additional payment models. We know Medicare Advantage plans are growing significantly. Some organizations have shied away from that. Maybe this is a time to start looking at those programs. Also, fee-for-service commercial insurance. It may be a time to start considering diversifying a little bit your revenue streams. And then we just want to leave you with a timeline, or I would like to leave you with a timeline. I know Bill has some final thoughts for us. Looking at a timeline, folks should have conducted their agency risk assessment last quarter, 2018, to give you an idea of what you need to do and start preparing for this year. And then this quarter, this is our preparedness plan for PDGM. let's go ahead and get that prepared so we can start executing that. Look at your industry partners in first quarter, and certainly start educating your staff. You'll see a little asterisk there because I believe you have to educate, educate, educate. This is going to have to be a repeated theme consistently and throughout the year. We're going to need to beta test that plan in quarter 2. And I know that sounds early, but remember, we got to plan for the unexpected. So if we go ahead and beta test the plan now, we can make those changes that we might need to make towards the end of the year. And then third quarter, we have to start educating our referral sources on the information that we're going to need them to give us. And we're going to have to repeat that education several times. And then quarter 4, of course, is our revision of our plan and our re-education, so that by November 19th, we won't start using new codes, we won't start using the new LUPA rates, but we will have our operations in place. We will be able to test drive it before we hit our go-live date of January 1st, 2020. Okay, and with that, we'll go to the next slide and turn it over to Bill.
Well, thank you, Tammy. And I think those listening in really could absorb a lot from what has been presented so far. David and Tammy both indicate a lot of great thinking has been going on, and we are getting very encouraged with the great thinking we're finding all across the country with home health agencies as we look towards 2020. Now, couple questions that routinely come in is whether there is any chance that PDGM will not happen on January 1st, 2020. Well, barring some completely unforeseen and extraordinary event, PDGM will go live on January 1st, 2020. However, in Washington terms, we would say, but it's not yet fully baked. What we mean by that is there is still work to be done somewhat within CMS in terms of tweaking some things, and they will come out with some rulemaking later this year that will give you a chance to see where they're going and comment on it and possibly seek some further revisions. But the question in terms of looking into the future is, can Congress help now for next year? And our answer is yes, Congress can, and our further answer is we believe Congress will. We have bipartisan support and something we call bicameral support as well in the Senate and in the House to move forward with legislation that would eliminate a behavioral adjustment on the front end of PDGM. It's one thing to have all of you go through the revolution of a new payment model within just the next 11 plus months. It's another thing to do so in the context of a base rate reduction. So we believe we can garner the forces at Congress in order to stop the potential of an upfront, in advance kind of rate adjustment that fits into the concept of a behavioral adjustment that was discussed earlier on. But we're going to need your help to make Congress get there. We expect legislation will be introduced within the next few weeks. In fact, it was planned to be introduced next week, but we want to make sure we have all of our co-sponsors in order, so we're going to take a little bit more time to green light our supporters for introducing the legislation. And that legislation will eliminate CMS's power to do an in-advance assumption-based adjustment. It would require CMS to make an adjustment only on the basis of real evidence of change in practices at the home health agencies that have been triggered by PDGM. And in the event that any change requires an adjustment to the rates, those adjustments would have to be phased in if they reach a 2% level. So can Congress help? The answer is yes, but we need you, and watch for us to call on you to be engaged, to connect in with your member of Congress in order to support this legislation. So looking into the future, we do see a very bright future for home health. We see demand exceeding supply, and we definitely see your ability to cope with changes of this nature, changes which we hope will actually not only modernize the program, but make it easier for you to serve the vast array of the population of Medicare enrollees who would be eligible for the home health benefit. So thanks for giving us a chance to talk with you today. And I guess now we shift it over to some questions and answers.
Great. Thanks, Bill, Tammy, and David. That was terrific. Just a quick reminder to all the participants on today's webinar, we will be sending out a copy of today's slide deck and recording after this session is done. And I encourage you to enter any questions you have on the right-hand side of the screen, and we'll see what we can get to here in the next 10 or 15 minutes. But I'd like to start the Q&A session off with David and ask a question. Will PDGM apply to other payers in addition to Medicare?
Well, I mean, clearly it's an alternative to PPS, and so it's most likely to be applied where PPS is being applied. We've seen historically that other payers would decide to graft onto models that have been used by CMS. They would have to be able to get the claims data in order to drive this in the same way that CMS would. But I don't see that as an immediate thing. Bill may have another thought on that.
There are very few Medicare Advantage plans that are currently using the home health PPS. And I'd agree with David that you can expect those plans that are using the current prospective payment system model to shift over at some point in time to PDGM. They're not required to do so. It may be worthy of checking in with your contract too to see, do they have an automatic switch to this? But like I said, it's highly unlikely. TRICARE, the program for military dependents, must move to this program as soon as it can once this program is finalized. But the VA and Medicaid programs have no obligation to do so, and we've not seen a propensity of them to use the Medicare prospective payment model.
Great. Thanks, guys. The next question probably directed towards Tammy. Looking at the PDGM model, what defines timing of early and late for everyone?
Sure. So the first 30 days are going to be considered early, and then our clock is going to reset when there's a 60-day gap in between periods of care. So, and again, that's going to come from our claims data. So CMS is going to track that for us to determine those early and late episodes.
Great, thanks. Next question is coming towards Bill, or coming for Bill. MedPAC has recently announced plans to cut $2 billion in spending out of the home health budget starting in 2020. What's the motivation behind that, and what will this do to agencies who may already receive decreased reimbursement under PDGM?
Well, this recommendation from MedPAC is just a continuing one. They have recommended for several years in a row now that Medicare home health payment rates be cut immediately at 5% and that Medicare go into another round of rate rebasing. The driver is one simple one from their view. They believe that the home health agency payment rates are overpaying home health agencies because the average Medicare margin, I wouldn't call it a profit margin, but the average Medicare margin is in excess of 15%. Now, we all know that that's not a real profit margin, and we also know that whatever margin Medicare gives does end up subsidizing Medicare Advantage and Medicaid uniformly across the country. That happens. But the driver for MedPAC simply is they don't think any Medicare provider of services in any sector should ever be paid at a level that leads to a 15% margin, and have made those same kinds of recommendations in all the other sectors over the years, nursing homes, hospice, hospitals, and the like. But it's all driven by their view that the payment rate is too high. Will it happen? Unlikely. That there will be pressure, as there has been for a while, but the fact being that unless the Congress is looking for money in order to support some other change they want in the Medicare program, they're highly unlikely to support that large of a cut. We saw that happen last year when they needed some money to deal with the outpatient therapy annual cap, and they came to home health and took a slice off of the inflation update. There is nothing like that on the immediate horizon where they would be taking money. But Congress, the offices we've talked to have pretty much across the board have said they're not going to cut rates by 5% or anything anywhere near anything the MedPAC has suggested. They will continue to look at it. but it's not on the agenda right now.
Great, thanks, Bill. The next question goes towards some of the timeline and planning that was discussed in today's presentation. Maybe this is for Tammy or for David. What type of internal is required to fully implement and use PDGM? Is there certain things to look at internally in your organizations to look to tap that leadership to make this all happen?
David, I'll take the first part of that and let you follow up with that. So I think internally, obviously we all have to do more with less. You have to tap those resources that you have in place. I would certainly look for that person that is a PDGM champion. They can do a lot of research. They can attend the webinars. As I said, there's so many thought leadership webinars out there now, and there's so many tools being produced by various organizations that organizations and agencies can take advantage of and use those as an internal resource to help them look at their PDGM KPIs. David, anything to add for that?
Something I'd add, I think, is somebody's going to need to be studying data. This is the kind of thing that can really sweep right in, where problems that you have now can sweep right into 2020 if they're not being monitored. And I think somebody's got to have the responsibility of looking at what's happening day to day and addressing the key issues that are raised here. Obviously, I'm hyped on the diagnoses. Somebody needs to be watching what's happening with that and able within their system to get at the information that'll help them to see where they're improving and who needs to improve.
If I could just add one little bit on that too, to echo what David's saying, data is extremely important because so much of what's talked about on PDGM are averages or something in the aggregate. Every single home health agency really needs to evaluate its own data, its case mix, its service model, its length of stay, its diagnosis of patients and the like, because this is not a model that has even impact across everybody. There will be winners and losers, but you make yourself a winner by seeing where you are and seeing what kind of changes you need to make in order to be successful under PDGM. And that may even include looking at where your referrals are coming from. So this is a multidimensional kind of change that people need to look at, and totally on board with what David said, which is, make it an evidence-based kind of planning.
Bill, I'd almost add to that. We could say there will be small losers and big losers rather than winners and losers. The shifts from one, shifting of resources from one category of service to another will cause some agencies to be able to see more revenue than they would have otherwise. But unless the diagnosis thing is addressed, everybody will be a loser, or each that doesn't address it will be a loser. Now, I harp on that because every time I talk to somebody and say, why on earth are these diagnoses, these R codes and so forth, still being used as diagnoses after all the complaining that has been done about this and the reaction of those who are certified coders, as regards their legitimacy? Despite, why hasn't this problem been addressed? And the reason it hasn't been addressed is that the information is not available. That's not something that we can solve just by ourselves. It's got to be solved with the help of other providers, and it's going to take time.
Great. Thanks, David. Following along the lines of the referral sources that were just mentioned by Bill, what can agencies do to help train and educate those referral sources, to help with this transition to PDGM?
Well, I don't think it's easy. I mean, you really certainly don't want to sit down for a few hours with a doctor and try to explain to that physician all about PDGM. So, quick talking points really necessary to show that this action is taking place is not driven by the home health agencies, but is driven by the Medicare program. Generally, that'll open up the door for further discussion. But an agency needs to take a look at what mix it has there and what are the patient categories that may bring additional reimbursement, and be able to indicate to those referral sources perhaps there's some increasing flexibility that will come through the new reimbursement model for those patients that are nursing intensive. And so the referral source, now knowing you might have the ability to be more generous in terms of the delivery of services, At the same time, I think there's going to be a need for education to those sources of patients where the patients are going to need therapy services, because there's going to be a tension to reduce therapy services. We have been on the bandwagon of trying to get people to understand that they may be hurting their own organization overall by reducing therapy services just because there's some reimbursement disincentives that are there. They have to take into consideration everything from value-based purchasing to home healthcare compare and star ratings when looking at what their pathways for care that might change. So educating the referral sources that there will be these kinds of issues related to the reimbursement and clinical pathways, I believe will go a long way to develop strong relationships with those referral sources. And getting new referral sources by looking at those categories of patients where there now are greater financial incentives to admit them into care.
Great, thanks. The next question will come towards Tammy. Tammy, during your presentation, you mentioned about 15 or so kind of risk factors. Are there one or two that are kind of most important that come to mind as agencies need to think about these preparations going forward?
Yeah, I think when we look at impact, for sure, the therapy utilization is going to be one of those risk factors that you're going to have to individualize for your agencies. Those organizations that have high therapy thresholds at this point are probably going to have a bigger potential impact than those that don't. So I would say that would be a primary one. I think the LUPA piece is going to be difficult for us to get a handle on, being 2 to 6, depending on if it's early or late. That's going to be a difficult one. But the biggest one of all, I have to agree with David, is going to be the coding. And the information is hard to get from referral sources. And just kind of to mention, I know some thought leaders out there that are looking at templates. I don't want to say it's like a face-to-face template, but some templates that may help organizations probe and get that information from referral sources. That might be, a tool that we can use with referral sources. And again, I always like to mention, because they're going to talk about the impact to their staff, right? They're going to have a huge impact in giving us this information and digging for this information. It's always a good time to bring about care plan oversight, cert and recertification. I don't know that all of our referral sources know about that and understand that. And then obviously relating it, as Bill said, to the value for the patient and the patient's outcome as well. If we can get this information, we can provide the services that we need to produce the outcomes we need and therefore reduce hospitalization rates.
Great, thanks, Tammy. We have time for one more question, and I would like to say thanks quickly to all the questions that have come in during today's presentation. Some of them are technical, but there's a high volume of them, and the team at Axxess after today's webinar will follow up with you on some of those questions. So thank you for that. And I think the last question will come for Bill. Bill, how do you think agencies are doing in preparedness today, and what can they do to come up to speed faster if they're behind?
I think Tammy mentioned, that there is a wealth of information coming from many, many sources. I will add a promo. We're doing one-day intensives across the country over the next 8 weeks. We did our first 2 yesterday and the day before in Kansas City and Orlando. Thank Axxess and many others for participating in that. And it really, you have to divide the information that you need to really get going into the following categories. One, you need to know the architecture, but beyond that, you need to have an operations plan, a financial approach understood as to the impact. You need to know clinically where things are going and need to go. You need to have sharp business analytics to be there, both knowing in a global fashion where things are, but knowing specifically where your own industry is. But you need to work with your technology partner, very much so, to make the transition to the new model work for you. The technology companies are rolling up their sleeves and pulling everything together, and they're demonstrating really to be a strong partner with the home health agencies to be there for 2020.
Great, thanks, Bill. This concludes today's presentation. As a reminder, Home Healthcare News will be sending out a recording of today's webinar and a copy of the slide deck. Please feel free to share that with your colleagues. Big thanks to Tammy, Bill, and David for today's presentation, and to Axxess for sponsoring today's webinar. I'm George Yednek with Home Healthcare News. Thanks for spending part of your day with us, and we look forward to seeing you on a future webinar. Have a great afternoon, everybody. Bye-bye.
Thank you for joining our on-demand training today. Axxess is the only home healthcare technology company approved by the American Nurses Credentialing Center to offer continuing education credits and the most recommended home health software on Software Advice. You can watch more on-demand training videos through our industry-leading help center or at axxess.com, where you'll find tutorials, blogs, white papers, and answers to frequently asked questions. Axxess, empowering care anytime, anywhere.